Good morning, good afternoon, and good evening from wherever you are. My name is Magdy El Ekiaby. I am a hematologist and working in Egypt as a director of one of the hemophilia treatment centers. I am your moderator for this session, International Von Willebrand Disease Guidelines and how to use them. Before we start this session, there are some housekeeping notes that I would like to share with you during this session. Yes, here we are. So for the interpretation, if you look to the left side bar of the screen, there is an orange button. If you click it from a laptop or a desktop, you will have a pop-up that will help you to choose the language for the presentation. If you are using a tablet mobile device, you need to use this icon to download the interpretation tool, and from there you can click and choose the language that you want for the interpretation. So at the end of this session, there will be a period for question and answer. You will find where the arrow is. You can click and then you can write down your question. And you will help me if you also will write the person you would like to ask, so that we can direct the question to one of my colleagues who are presenting during this session. Next, please. At the end of the session, there is a polling question to evaluate the session. I hope you will all do this in order to help us improve the next programs by listening to your opinion. Next, please. So if you have any technical problems, you can email to Christina Mills. If to these speakers and moderators, you will email to Ellen Lassier, and in interpretation, you can email to Emily Rahim. Next, please. So for this, before we start, we have a small testimonial video by Abira Maheen.
Hi everyone, my name is Abira Maheen and I'm from Pakistan. I would like to start by thanking WFH for providing us with this opportunity to represent the female bleeding disorder community of Pakistan at an international forum and to get our voices heard. Starting off with a brief introduction, I'm a doctor by profession and I have been filling in the position of Joint Secretary of Hemophilia Foundation-Pakistan, which is the NMO of WFH. And I have a special interest in working with the youth and the women of the bleeding disorder community of Pakistan and training them and getting them into leadership roles. WFH have been playing a role of a sort of a guardian for Pakistan, and they've not only provided us with philanthropic support, they have not only been providing us with the humanitarian aid, but also with opportunities to train the leadership community and to build great leaders of the bleeding disorder community of Pakistan. Talking about the bleeding disorders, I have von Willebrand disease type 3, which is basically the most severe form of von Willebrand, and that is the most prevalent form of von Willebrand disease in our country, Pakistan. Living with the bleeding disorders was obviously not an easy task. There were a lot of hurdles that had to be overcome, but We have such a strong network of individuals that have been successful in establishing non-profit organizations that intend to help people with such disorders, and they've such committed people. They've dedicated their lives for this purpose, and they've been working really hard despite government not being involved, and that is the main concern that we are facing right now. Hemophilia Foundation-Pakistan have been striving really hard, and they've been successful in getting the government involved for the bleeding disorder community of Pakistan. In Pakistan, we have a male dominant society. Getting the females represent themselves is a huge task itself. But AJP have been very successful in providing heaps of opportunities for such females, and to get them build their capacities and to represent themselves and get their voices heard. I hope to work with the Hemophilia Foundation Pakistan, with WFAs, and I hope to work uncommonly for the female bleeding disorder community of Pakistan, to get them connected, to get them involved, to get them represent themselves, give them hope, give them expectations, and to build them at such a level that they can not only represent themselves, they can not only play an important role as individuals, but they also play a role as useful individuals for the community, for the bleeding disorder community, for the country as a whole. And in the end, I would like to state that obviously difficulties are part of life. Everyone has to face them. Everyone has different kind of difficulties. It all depends how you face them, how you confront them, how you move on with them, and to cope with them, accept them, move on with them, and serve the humanity will not only make our life useful or our life better, but everyone around us. Thank you, everyone. Have a good day.
Thank you very much. This was an important message about the VWD and the other bleeding disorders and the challenges of women. So through this session, we will discuss the International Von Willebrand Disease Guidelines and how to use them. And before I start, I would like to congratulate WFH and all the committee of the Women with Bleeding Disorders to have this first Women and Girl Global Summit. It's a huge achievement, and we hope that from this we will move forward to improve the quality of life for our women who are suffering from these disorders. So I wanted to simplify. First, these are my disclosures. So what is a treatment guideline? A treatment guideline is a systematically developed statement designed to assist practitioners and patients to make decisions about appropriate health care for specific clinical circumstances. So it's more structured guidance to patients and clinicians on knowing their diseases and how to best treat or manage their conditions. So what is the importance of the treatment guidelines? These are just few bullet points, and I believe that it will be more covered in more details by my colleagues during their presentations. So they are primarily intended to help clinicians make decisions about diagnostic and treatment alternatives. And it is a very important tool for advocacy and to reach out for policy, education, to better care for our patients. They may also be used by patients to help them make informed decisions, and this will be mainly through their national member organizations trying to simplify the statements and make it understandable to the patients. They are not intended, the guidelines, to serve as a standard of care, and clinicians and patients must make decisions based on the condition of the patient, the values of their community, and at the end, it cannot be totally applied in some communities because of the realities of a specific clinical settings or local resources, included but not limited to institutions to be locally adapted in a way that we can achieve the best possible outcome. So with this, I would like to introduce Dr. Paula James. And Dr. Paula James is a professor of medicine at Queen's University, and she holds cross appointment to the Department of Pathology and Molecular Medicine and Pediatrics. She is the medical director of the Inherited Bleeding Disorders Clinic of Southeastern Ontario. She has more than 115 publications, and she is the co-chair of the Von Factor ISTH SSC from 2010 to 2014, and clinical co-chair of ASH ISTH NHF WFH Von Willebrand Disease Guidelines Diagnosis Panel. So she is the best to inform us about what's new in the Von Willebrand Disease Guideline regarding the diagnostics. Please, Paula.
Thank you very much. Thank you for that introduction. And I really want to thank WFH and also echo my congratulations for putting on this first global summit on women and girls with inherited bleeding disorders. I'm really delighted to be involved today and to talk to you about this massive project, which is just coming to a first stage of closure. But as you're going to hear, there are many plans and things still to come. So these are my disclosures. I've got research funding from a number of companies that make concentrates that we use to treat patients with von Willebrand's disease. So this guideline has truly been a collaborative effort of 4 important organizations globally when it comes to bleeding disorders. The lead organization was the American Society of Hematology, who partnered with ISTH, the National Hemophilia Foundation from the US, and the World Federation of Hemophilia to carry this project out. So as already stated, the goal of our work was to produce clinical recommendations for the diagnosis and management of VWD. And it's critically important to understand that we did this to improve care for patients. That was the focus of every decision that we made, was what would help patients improve their quality of life, improve access to care, make diagnosis more timely. We took the perspective of a high resource setting, really to try to set a goal of what is it that we would like to see optimally, recognizing though that not everybody lives in a high resource setting. And so we definitely have future plans to adapt the guideline for other healthcare systems and for other countries. So I thought I would explain a little bit about what the process looked like so you can understand how we came up with the guidelines and our recommendations. We decided a number of years ago that we wanted to have 2 panels, one focused on diagnosis and one focused on management. The panel members represented hematologists with expertise in caring for patients with bleeding disorders, pediatricians, gynecologists, basic scientists. But as I already alluded to, and you're going to hear this as a theme throughout this session, the patient input was critical. Patients obviously have a unique perspective that scientists and healthcare providers try to understand, but we really wanted to hear that from the patients themselves. And so on both panels, we had a number of patients as full voting members. This also in the guideline world is a way of safeguarding against conflict of interest so that it's not some secret panel making decisions behind closed doors, that the people who the guidelines are intended to help are part of the entire process. The people who served on the panels were nominated by the partner organizations that I showed previously. And we aimed for geographic diversity with representation from North and South America, from Europe, from Australia, and from New Zealand. We were very ably assisted by the methods team from the Kansas University Medical Center and made a decision to use the GRADE methodology, which follows what we call PICO question determination. And PICO stands for patient intervention, comparator, and outcome. So for each question that we made a recommendation about, we thought about who are the patients specifically that this recommendation applies to, what is the intervention that we want to recommend for or against, what's the alternative to that intervention, and then what are the important outcomes that we're trying to improve on for patients. There was no industry funding or involvement in the process whatsoever. And we had fairly strict conflict of interest contracts with ASH that all of the panel members had to follow the entire time through the process. And so we were not allowed to have any direct financial relationships with industry, or if there were direct relationships, panelists may have been recused from voting on recommendations that that relationship could have had an effect on. And so this is a brief timeline to give you an idea of the scope of the project. And in fact, I was looking at this slide earlier, and my involvement actually started a couple of years before this slide even. So in 2015, through my involvement with the VWD and Rare Bleeding Disorder Subcommittee of WFH, there was some discussion about the need for an international guideline. And myself and Dr. Flora Pavandi and Dr. Tom Absher put together a proposal that went to WFH and was received very favorably. Around the same time, similar discussions were happening within the leadership of ASH and ISTH and NHF, who had produced a position statement saying that there was really a need for this. And so Dr. Nathan Cannell and I put together a proposal with some assistance from other members of the community to launch this international project, and that was approved in 2017. And so then over the summer of 2018, we carried out a scoping survey, and I'm going to show you some of the data from that. And really the idea was for us to get as much input as we could from the global community on what the guidelines were going to focus on. So what were the most important areas? Where could we have the biggest impact? Late summer 2018, the panel members met for the first time to finalize the PICOs that we were then going to go forward with the guideline. And then over a period from August of 2018 to January of 2020, the methods team underwent very detailed and involved systematic reviews and reviewing of the evidence. This was thousands of hours of work that led to our second in-person meetings, which took place for each of the panels over 2 days in January of 2020. And when I look back, I'm very grateful that we managed to get those meetings in person before the pandemic hit. And so during those meetings, we finalized our recommendations, at least in draft form. They were then put out for public comment over a period of about 6 weeks in the spring of 2020. And despite the fact that all of us were affected very much by the global pandemic, we had incredible input from the community and took all of that into account. To draft the papers, which have actually now been submitted, have undergone peer review, the revisions have been submitted, and the papers have been accepted. And we are hoping to see the publications probably not December 2020, probably early January 2021. The papers will be published in Blood Advances. And so I mentioned the scoping survey that we undertook in the summer of 2018 to figure out what questions the panel was going to focus on. This took place in English, French, and Spanish, and WFH was critical in translating the survey so that it could be more widely distributed. We had responses from 601 participants, and of all of the guidelines that any of the people involved in the process had participated in, this was the largest response anybody had ever seen by a lot in terms of the community engaging and giving us direction. And so that's been the theme all the way through, that this community has been so engaged in giving us guidance. Of those 601 participants, half were patients or caregivers. And so at every stage, the patient voice was really critical. And about half were healthcare providers, individuals looking after patients with von Willebrand's disease. We had nearly 10,000 comments that were submitted, and every one was reviewed and considered. Over half the comments came from women, about 21% from men, and the remainder didn't specify. 18% came from lower or middle income settings, and about 60% received care at a comprehensive care center, at a hemophilia treatment center. And so you can see on this map where that feedback came from. So the patients or caregivers are in blue and healthcare providers are in orange on this map. And so we had pretty good global input into what these guidelines were going to focus on. And this slide is something that we're very proud of and have published already in a paper describing the scoping survey in the journal Hemophilia. And this is what we heard. The priorities from a diagnostic point of view were the diagnostic criteria and bleeding assessment tools. From a management point of view, we were tasked to focus on treatment for women, surgery and procedures, as well as prophylaxis. So the diagnosis panel has made 11 recommendations. The management panel has made 12. In terms of additional feedback, as I mentioned, we had this public comment period that took place in the spring of 2020. Usually ASH posts draft guideline recommendations for about a month. We extended that because we recognized that people were having different stressors on their time because of the pandemic. And I would say that for the most part, the feedback that we got was positive, that there was a lot of support for the recommendations that we had made, but we had nearly 200 individual comments. And I can promise you that Drs. Flood, Cannell, and myself went through these one by one and really thought through what we were hearing from the community and what changes we needed to make in the recommendations, if any, or what additional information we needed to provide so that it was clear to the community what the panel had been thinking about. So I'm just going to preview one of the recommendations. The point of this session, I think, is to talk more about advocacy and empowerment and how we use the guidelines, but just to give you a little bit of a window into how this worked. And so this is one of the PICO questions that we set for the diagnosis panel. So in patients with an abnormal initial VWD screen, so low VWD antigen or platelet-dependent VWF activity, either the ristocetin cofactor or a GP1BM, and who are suspected of type 1 VWD, should we set the diagnostic cutoff of at less than 0.0 or less than 30% or less than 50%? And so the recommendation that we have made recommends that for a VWF level of less than 0.30, patients should be diagnosed with type 1 VWD. For anyone with abnormal bleeding and levels less than 0.50, those individuals should also be diagnosed with type 1 VWD. And this was a strong recommendation, although based on low certainty in the evidence. And you can see the remarks that we made with this recommendation, that by VWF level, we're talking about antigen and or the activity assay. We use 0.50 as a convenient and a bit of a shorthand in the wording of the recommendation itself, but we really want you to look at the lower limit of the normal range in your local laboratory and use that if it's less than 0.50, and that we do not think ABO specific reference ranges need to be used. We also make a comment about the fact that VWF is an acute phase reactant that increases in response to a variety of stimuli, acute bleeds, trauma, pregnancy, and so that VWD diagnostic testing needs to be made when patients are at a baseline state of health. And then to give you an idea of what the evidence to decision framework looks like, these are the papers that we considered and the evidence that we looked at to come to that recommendation. There were 9 studies, and you can see the breakdown of what those studies focused on. A number were looking at mutations that were found in type 1. 2 were focused on correlations between VWF levels and bleeding score. 4 looked at likelihood ratios or odds ratios, and 2 looked at the prospective evaluation of patients or diagnostic accuracy when patients are seen in the clinic. And this is a really important point for this recommendation, and in fact for all of the recommendations the diagnosis panel made, which is that our priority was to not miss cases. And so we want to ensure access to care for everyone with von Willebrand's disease, recognizing that even if we got this wrong a little bit, that patients can benefit from treatments for bleeding, even if they don't clearly have von Willebrand's disease. And so this is a summary of the papers that we looked at with the risk of bias. This is a pretty good table like this for these guidelines, that these papers were generally considered to have a low or only moderate risk of bias. So reasonably solid evidence. We looked at the papers that were evaluating the frequency of a mutation in the VWF gene. And you can see that we were more likely to find a mutation the lower the VWF level. This is a paper reported by Dr. Veronica Flood, but there are other papers that have shown something similar. Of critical importance, though, bleeding is not more likely with a lower VWF level. And that's really why we said, we're not going to say type 1 is only for individuals with levels less than 0.30, that if you have abnormal bleeding, you should be diagnosed with type 1 with levels less than 0.50. We looked at papers that evaluated likelihood ratios, and you can see that a high likelihood ratio of having von Willebrand's disease, which is in the green, was strongest for VWF levels less than 0.40 or 40%. And so the panel very seriously considered setting this type 1 cutoff at 40%, but we didn't do that because of that overarching principle that we wanted to be as inclusive as possible and capture as many patients as possible with a clear diagnostic label so that they had access to the care that they needed. And then the last consideration was those papers that looked prospectively at diagnostic test accuracy. We caught more patients. The sensitivity was better if we had a higher cutoff. So hopefully that gave you just a little bit of a window into the amount of thought and consideration that went into generating each of the recommendations. The process looked like that, with that kind of detailed review of the evidence. And so what I've shown you today is just a summary, a brief overview of what this process looked like for the first collaborative VWD guidelines that had multiple international partners. This is the first VWD guideline that had patient involvement. We had very high community engagement, which we're delighted about. The papers will be out very soon. And we have started already, months ago actually, we started having meetings about implementation and dissemination planning to make sure that what we've done is digestible to the community for patients and for caregivers and for clinicians and for patient organizations. And so you're going to hear from my colleagues in the rest of this session their perspectives on how we take these publications and continue to work to improve patient care. And so I want to acknowledge my absolute dream team, the leadership for this guideline process. I've referred to these individuals throughout the presentation: Dr. Nathan Cannell, Dr. Veronica Flood, and Dr. Reem Mustafa, who was the methods chair that led that team in the US that did all of the very detailed evidence review and systematic review. So this was a dream team to work with, and a pleasure for me to have been involved with them. And so with that, I thank you for your attention, and I'm happy to take questions during the question period. And I'm going to pass it on to my co-presenter. Thank you for your attention.
Thank you very much, Paula. This is really a very good job to, in a very short time, to give an overview to the guidelines. Of course, we'll have questions to you by the question and answer session. Now it's my pleasure to introduce Susie Couper. Susie is a patient with von Willebrand disease type 3. And as she mentioned, she was only diagnosed when her son was diagnosed with type 3 von Willebrand disease. So for about of the disease without knowing that she has this disease. In addition to this, she is an active member of the committee on the non-profit organization in Perth, Western Australia, and she is working in close collaboration with the Hemophilia Foundation of Australia, as well as with the WFH on the programs for the von Willebrand disease. And now she will enlighten us about how can patients use these new guidelines. Please, Susie.
Thank you, Magdy, for that wonderful introduction, and welcome everybody to this session. So my name's Susie, I'm from Perth in Western Australia. So these are my disclosures. The only thing to mention is honoraria from ASH as a patient representative. Okay, so the guidelines, as Paula went through before, and I don't want to understate how important it is, a collaborative effort. And it shows an extensive commitment to addressing the needs of people with von Willebrand's disease in a comprehensive way. And I can't underestimate how much of a difference this is going to make. So patient representatives were actively involved in every stage. So I'm proud to be able to acknowledge my involvement as a patient representative. I had to keep it confidential for a very long time, which was hard to uphold, but it was important to deal with that conflict of interest. So it's great that I can proudly speak about it finally. So through many calls and meetings that patients were listened to, our opinions were actively sought and taken into account. We weren't only observers. There were some healthy challenges that we brought to the project, and we received a high level of care and consideration from the methods team, the chairs, and all the other panelists. So the way I view the guidelines is that they're an expression of a deep commitment to patient-centred care and improved health outcomes. The patient-centred care puts us inside the decision-making. It's about valuing the differences that we have in our priorities and what we want out of treatment, and acknowledging that we're not numbers, we're people. So with the guidelines, there are a lot of opportunities to learn more, and research objectives were discussed out of the gaps that came out of the learnings and the recommendations. And I can only hope that these research objectives result in more studies. So watch out for them and see how you can contribute and affect change. So I'm sure you all want to know where and when you can find them. But before we get to that, I actually want to talk about, as patients, what's constructive and useful to know about the guidelines. So as Paula explained, the guidelines are systematically developed and they're primarily intended to help clinicians make decisions. And from a patient perspective, that actually means that they're not super user-friendly for patients at the moment, but that's okay. What I want everyone to understand is that watch the space, and it's going to change with future developments. It's not a static project, it's not finished. So healthcare professionals will also likely benefit from the development of education tools as well. So there's lots of interesting work to come. They're not a patient tool like the Self-BAT tool. So if you haven't looked at the Let's Talk Period website, go and have a look. I highly recommend it. It's easy to use, and because it's factual, it can take the guesswork out of knowing whether you should encourage somebody to seek specialist advice on their bleeding. So I kind of look at that as a bit of a gold standard for things that patients can use. That's my intention for what we can actually start to build out of the guidelines, things that patients can directly interact with. The guidelines don't address all treatment situations. There was a limit on the number of questions and variations that could be covered. So there was, as Paula discussed, an extensive prioritisation activity to choose the questions with the survey as well. So as a patient, when you're reading the guidelines, if you're looking at those questions and you're thinking, oh, well, hang on, there's something in here that I'm curious about, or there's something that's not in here that I'm curious about. And if it's not in the guidelines, still raise it with your healthcare professional. It's not the only things that you can discuss. So this was something that I've never been involved in any of the methodological practices. So I was quite curious to see how it all worked with recommendations. And the recommendations might be strong or weak, but that doesn't necessarily mean that their treatment choice is suitable or unsuitable. A weak recommendation is not a bad recommendation. It just means that there's a lot more work to do. So with the guidelines, there'll be good practice statements that you can read through and find more information. And this might be something that you want to check in with your healthcare professional about and make sure that they're actually understanding what those good practice statements are talking about. So the gaps in research evidence will be the cause of weak recommendations, not the treatment options themselves. So research gaps don't always mean that nobody wants to do the studies. It could be that there are ethical reasons. I mean, can you imagine being the one on the list and they're double blind for a major surgery? It's not necessarily going to be as easy as all of that. So now we can talk about some details. So as mentioned before, you will be able to review the full guidelines when they're published on Blood Advances. So that's open access. Anybody can see the articles in it, and the guidelines will be accessible to everybody. So the website's there, you can hop on and have a look. You can share it around, but also I encourage you to have a look and see what else is in there. I've also put up the details for the World Federation of Hemophilia Facebook group, and you can stay there connected, see all the announcements and see what else is happening as well. I'd recommend for people to stay connected on the socials and watch out for announcements and be part of the community. You might be the only one in your network to see this, and then you can start to share information amongst your community. So I was hoping to be able to say that these were already live, but as Paula's mentioned, it'll be January before you'll be able to get to them. But upcoming in January, there will be the ASH Guidelines for Diagnosis and Management of Von Willebrand Disease seminar. So if you want to take a deeper dive and learn a lot more, watch out for that as a great opportunity. So I want to talk now a little bit more about as a patient, what are some of the things you can do when you're talking to your healthcare provider? So check in with them, see if they know about the guidelines. And if they don't, maybe you can start to ask that question, well, why don't they know about it? But within that, I would just say that having a collaborative approach with your healthcare professional is always going to be the most useful. And then think about who your provider is, and are you linked in with a haemophilia treatment centre or a comprehensive care facility as well? So in Australia, we recommend going through an HTC, and that way you're assured of best practice and the up-to-date treatment. Think about shared decision making. Focus on what your desired outcomes are. Think about quality of life and what matters to you. What are your goals? What are the things that you want to be able to do? But also, it's still important to think about what you don't want and to speak to this and not have things assumed. Because quite often, if you don't speak up about what you don't want to have happen, that part's going to be missed with your healthcare provider as well. There's going to be knowledge gaps. There's wide variability and there's lots of new information. And now's a good time to challenge assumptions and look at new and different options. Be curious, be informed, but keep some humility with your pride as well. And we're all learning. Sometimes as patients, we teach our healthcare professionals because we're our best experts. And sometimes they teach us. So be humble with your assertiveness and remember that your healthcare professionals, they're people too. And a final tip, and this is a really important part, because not everybody can come along into the summit. Spread the word, tell your community, and remember that sometimes we need to hear a message more than once to grasp it. So thank you.
Thank you very much, Susie. This is really a great presentation, and it's like a translational way from a complicated scientific knowledge into simplified words to our patient community. And I'm sure that we will need much more work on this. Now it's my pleasure to introduce my dear colleague, Claudia. Claudia is an assistant professor at San Joseph University in Beirut, and she is a pediatric hematologist working in Hôtel Dieu France Hospital in Beirut as well. She's having many tasks for bleeding community in Lebanon. Among it is the multidisciplinary care team, and as well as a medical advisor to the Lebanese Hemophilia Association. And she has a lot of work on von Willebrand disease, factor VIII, and other rare bleeding disorders. And she is also part of the Hemophilia East Mediterranean network that we share together. And she will talk to us about the perspective of the healthcare professionals on how to use these new guidelines. Please, Claudia.
Hello, everyone. So my task today is how healthcare professionals can use the von Willebrand International Guideline to advocate for better resources and care. Here are my disclosure. In fact, I know that we heard a lot about what could be international von Willebrand guideline, but I will stress a little bit more on three items. In fact, guidelines is an indication, outline of policy or a conduct. It is developed from a systemic review of evidence. It highlights the priority and main topics. So I think guidelines are really perhaps not the most important, but very important tool for advocacy. Again, what could be von Willebrand? We heard a lot about von Willebrand, but I would say that von Willebrand is perhaps the most common hereditary bleeding disorder. But if we look to the prevalence in a population-based study and specialized center, there is really a huge difference. And again, the complex structure of the protein and the wide range of plasma level encountered in the population make laboratory assessment and diagnosis a challenging proposition. It includes a range of subtypes of variable severity with differing management requirements. Individuals with von Willebrand will also be seen by health professionals other than specialized hematologists. So all this, let us say that there is a problem and there is an urgent need to improve care and treatment for von Willebrand disease. And the question that we could have is how we will do it. And I will say perhaps advocacy, it will be a way, but we will advocate for what? And what will be our target of advocacy? First, I think we need to access to diagnosis because there is a huge gap between the numbers we have all over the world and the reality. So we have to target, I think, first-line doctors first, perhaps lab physician, but if it's for a huge diagnosis, it's first-line doctor first. And I think patient families are important because there is a lot of cases in family and we don't know about them. So we need easier and simple tool of diagnosis. It's really a need. And if you look to the different guidelines you can read, you see that the tools that you can use are perhaps bleeding assessment tools and specific blood testing, mainly antigen von Willebrand activity and factor VIII level. I will share with you a small experience of outreach in Lebanon. In fact, in Lebanon, because we have this gap between, we don't have the number of von Willebrand we must have, we decide to outreach in the region where we think that the level could be higher than other parts. And we go to first-line public health care in the region, where we educated the healthcare about bleeding disorder a little bit, and we asked them to have have a small questionnaire and to do a bleeding score and a pictorial bleeding assessment with all the ladies coming to the healthcare after certainly educating the health professional to these tools. And in the same times, people who comes to this healthcare that are mainly women in our region because they come there and with the children because they cannot afford to pay a doctor. They will have access to some educational pamphlet about bleeding disorder and what could be a bleeding disorder. And after filling this questionnaire, and if the bleeding score was more than 3 in our study, and if the pictorial bleeding assessment was high, we propose a blood test for our patient. We decide to choose simple tests, TP, PTT, bleeding time, CBC, and just histiocytin cofactor activity measured by agglutination method. Certainly, it's not the best way, but it was the only way we have in our country, and I think it's better than nothing. And what I could say is that with this outreach program that was during 6 months, I would say, the disease was better known in the region, and after the immediate questionnaire, 1.4% of the studied population. We discovered 1% of von Willebrand who were totally unknown. And I think this was good. And even after this study, the healthcare professional from the region sent us a lot of persons who were in their mind eligible to have a bleeding disorder, knowing now the bleeding score and what could be a bleeding score. Sorry. I think the second problem we can have is getting access to safe, affordable, and effective treatment. And this is a problem perhaps not in a country, a developed country, but in country like mine, like a lot of countries in the world, this is a big problem. And usually the target to have this treatment is a health authority, the patient also, because sometimes they don't understand the use of treatment, and the healthcare professional. So before going and say how to do it, I think that we have to remember how to treat von Willebrand disease. There are 3 general strategies. The first is to increase the plasma concentration on von Willebrand to release endogenous von Willebrand stores through stimulation of endothelial cells with desmopressin. The second approach is to replace von Willebrand factor with concentrate or whatever. And the third strategy uses agents that promote hemostasis and wound healing, but do not substantially alter the plasma concentration of von Willebrand factor. The 3 treatment options are not mutually exclusive, and patients may receive any one of all classes of agent at the same time. So, saying that, I think that it is really important when you want to treat people to advocate for desmopressin first, because we know that the majority of patients are not severe case. And anyhow, whatever is the severity, in patients in whom desmopressin is valid treatment option and who have baseline less than 30 units per deciliter, I think it's important to advocate to a trial of desmopressin and to treat them based on the results, because it will preserve costly resource for patients who need concentrate, and inequity would be reduced certainly when you have more treatment. In Lebanon, what we have done for desmopressin, before 2019, desmopressin was available in the country, but certainly underused. So our target was not the Ministry of Health or whatever, it was mainly patient and hematologist, because for them, they have von Willebrand disease, they take von Willebrand concentrates. It's something like this, not something else. So it was during every consultation with a von Willebrand patient, we discussed about DDIVP and the effect of DDIVP and how it's work, and we propose to do a test. And in fact, we don't have the nasal DDIVP nor the intramuscular DDIVP. We just have the IV form. And we decide, and what also is important to know is that our country is not a rich country, and we don't have a health care system very well established. So our patients with von Willebrand disease do not have access to treatment in an easy way. So what we decide is that we will do our trial of DDIVP as an outpatient clinic setting. So the patient come in the clinic and we do the subacute DDIVP. We explain what will go and what we do the observation needed during the first hour. And we have withdrawal 1 hour after, and if they have more money, 4 hours after, to see how it's worked. And according to the results, the patient use them at home then after. And for hematologists, with every meeting we have, with every session on von Willebrand, we stress on DDIVP. Now, after 2019, the product is not available anymore in our country for political reasons. And now our target is mainly health care authority to have access again to this drug in the country. But Willebrand concentrate, we have to remember that DDIVP is very good, but it's not the only treatment, and sometimes von Willebrand concentrate could be the only life-saving product. And so we must advocate to have this product, and we have to advocate mainly with health authority, because they are the one who will pay this product. So we have to tell them that DDIVP is not the treatment for everything. It's generally contraindicated in type 3 patients due to the lack of efficiency, and in type 2B also due to the increased platelets binding with subsequent thrombocytopenia. Many patients with type 2D will not respond to desmopressin and require other mode of treatment. Patients who will have major surgery will need this product, and even with if there is small amount of bleeding, it may result in critical organ damage sometimes. And it's generally contraindicated DDIVP with cardiovascular disease under the age of 2, with type 1C, and in preeclampsia, pregnant patients with preeclampsia. So there is certainly a need to continuously advocate for von Willebrand factor concentrate. Other treatments that we must advocate for is tranexamic acid. It's because tranexamic acids, as you all know, improve hemostasis with high value on the benefit of reducing bleeds. In adjunction with von Willebrand and DDIVP, it will provide the most desirable effect with regard to hemostasis. Alone, it increases equity because it's the easiest and cheapest option and may open up the option of minor surgery for patients. Alone again, it could treat heavy menstruation bleeding. It is very useful during the postpartum period. It is safe, cheap, and feasible to implement. It has a less harmful and desirable effect in comparison to therapy used to increase von Willebrand factor. And also, it is safe during breastfeeding. What you have done with tranexamic acid in Lebanon is we mainly advocate for tranexamic acid with patients, and more specifically women, as you can understand. And usually at each medical consultation, whatever is a consultation, we discuss all the time about tranexamic acid. And what we have done recently is an educational program in collaboration with the Hemophilia Association, Lebanese Hemophilia Association, where we have an outreach program that is running to let girls and women understand what is menstruation. As you can imagine, we heard from other sessions before, in the region, in the Middle East region, Arab region, and a lot of other areas in Africa, menstruation is still a taboo, and people do not discuss about it, and they don't know, and they live this period very badly. So we have done a program to let them know what is menstruation, And the tool we used during this program was, we have done a pictorial chart assessment. We do a quality of life questionnaire. We do a workshop on what is normal menstruation and what could be hormonal therapy. And in fact, the aim of this is to screen new patients. It's to lift the taboo around hormonal therapy and advocate for the use of tranexamic acid. And believe me, it's work and it helps a lot. With this drug, like tranexamic acid, we could change the life of a lot of women. The second problem, the second advocacy field in our experience is with the gynecologist. It's terrible, but in our country, gynecologists do not know this drug at all, and I think it's perhaps in other countries also. And we have to talk a lot because, as you will see after, sometimes women with von Willebrand disease go only to gynecologists and never come to us. And the other side, sometimes they come to us and they never want to go to gynecologists. So we advocate every time we have a woman coming from a gynecologist that reach us. We try to talk to him, to explain him what could be tranexamic acid, and we try to do a workshop and session with gynecologist as attendee to discuss about menstrual bleeding and in women with bleeding disorder. Again, we advocate for tranexamic acid with anesthesiologist and family doctor. And finally, I would say that we advocate for the availability of tranexamic acid with pharmaceutical. Unfortunately, this drug is cheap, so it's not interesting for them to bring this drug to the country. So even if it's registered in the Ministry of Health, the pharmaceutics do not bring the drug, and it is always difficult to have this kind of drug in the country. Finally, I would say that there is need of prophylaxis for severe bleeders. And here we have to target health authorities, certainly, patient and healthcare professional. While prophylaxis we have to advocate for, because there is a net benefit on health outcome from using prophylaxis over no prophylaxis in von Willebrand disease patient with history of severe and frequent bleed. If you look to the different publication done, we see that there is near 50% decrease in the number of bleed per year. And if you try to understand if the different studies are in favor of prophylaxis or not in favor, it's really clear that all the studies are more in favor of prophylaxis. Certainly not for every patient, but for the severe case of a von Willebrand patient. Then I would say that what is certainly needed is comprehensive care for person living with von Willebrand disease. And here we have to target patients in our country, for example, and healthcare professionals also. Why multidisciplinary team? Because we know that von Willebrand patient could have numerous different medical problems. For example, we can have cardiovascular problem and we need anticoagulant, and then we have to decide what to do. And the patient considered for anticoagulant or antiplatelet treatments require individual risk and benefit on the specific therapy plan in conjunction with multidisciplinary teams that include cardiovascular medicine specialists, hematologists, and the patient. Again, if you look to gynecologist and woman bleeder, we need multidisciplinary clinics in which gynecologists and hematologists see patients jointly to facilitate the management of heavy menstrual bleeding, pregnancy, delivery, postpartum period for patients with bleeding disorder. Here, we know also in other parts that a woman with bleeding disorder have certainly bleeding disorder, but have also gynecologic problem, and you have to push them to go to see gynecologists for standard problem that we cannot manage. There is also work we have to do with anesthesiologists, and in the context of this session in women, we have to have decision about delivery, how we will do it, what level of factor we need for neuraxial anesthesia, what could be the thrombotic risk, could we give the IVP or not? And here again, we need a multidisciplinary discussion with input from anesthesia, hematologist, obstetric, patient, and this discussion should take place well in advance of the patient due date. Again, we have to work with surgeon, dentist, to decide for major surgery, minor surgery, what to do, how to monitor, how much day, what kind of treatment we give, and tranexamic alone or VDIVP or whatever.
1 minute, Claudia, please.
Yeah. So I will just give you in the context of multidisciplinary disciplinary management, the Lebanese experience. I will give you the context. In our country, we have one center of care in the country based on voluntary work. All healthcare provider of the center of care are outside the center, do not work they work outside this center because they need to live for living. Patients are not usually covered for their consultation fee in the country. So to bill them in Ethiopia is very difficult when they don't have money, and people with rare bleeding disorder are in problem. Doctors are still considered like half gods and must be multifunctional. They don't understand that they have to see other doctors. You must resolve everything. And multidisciplinary comprehensive care are really mandatory to implement. So what we have done, we create a virtual network all over the country from the center of care, the voluntary sort of center of care, with volunteer committed physicians from different specialty. The conductor is usually the hematologist. The soloists are physio, gyneco, orthopedist, social worker, psychologist, dentist, all over the region. And sometimes we can have invited guests like anesthesiologists. And usually connection and communication are phone, mails, and mainly WhatsApp. And with our patient, the main communication is WhatsApp. So I just want to say that we outreach physician and patient to multidisciplinary teamwork, and we want mainly to empower our patient, because we have to remember that the best ambassador for adequate care is an educated patient. And we believe that if our patient understand very well the disease, know what to do, what could be the guidelines, what could be the treatment, the management, wherever they go, even if they are not in the care center of hemophilia or bleeding disorder, they will push the physician they see to do what they have to do and to get in connection with the center who knows the disease. So I will say finally that using the guideline to empower healthcare professionals, how to do it. We know that clinical practice guidelines are able to provide the rapid means of providing consensus, explicit and prejudiced use of current best evidence without the time normally required to gather such evidence. Implementation and use of clinical guidelines improve certainly health outcome. Guidelines can improve the consistency of care. They improve the quality of clinical decision. They support quality improvement activity. They shine on gap on the evidence and improve medical research. And they may be effective in improving efficiency and optimizing value for money. Healthcare system that provides services and government body and private user that pay for them understand it. And to finish, I will say that to advocate, and we need to remember the principle of advocacy, we need clarity of purpose, safeguard, confidentiality, equality and diversity, empowerment and putting people first. Guidelines are really mandatory in the toolkit of advocacy. They are really your backup when you will go to people and discuss with them. Thanks a lot. I finished.
Yeah, thank you very much, Claudia. This is really a very comprehensive presentation discussing the points that maybe where guidelines can be implemented, and showing the practical Lebanese experience on this. So now this is the question and answer, and we have several questions. So the first question to Paula, please. Someone was asking if you have interacted with the regulators while preparing these guidelines, and what were the impact of this communication, if it at all happened?
Yeah, that's a great question. So regulators were not directly involved. We didn't have regulators as panel members, but I can tell you that as we were making our deliberations around what our recommendations were going to be, we often would say to ourselves, okay, what impact is this going to have on policy, or what is a regulator's perspective going to be on this? And we were never hindered by the idea that a regulator might not support us advocating for increased access to care or better treatment for patients. So they were not directly involved. We did keep them in mind. We actually have started interacting with them now. And so one example is that we've been working through ASH with a group that is involved in determining ICD diagnostic codes for the United States. And they're actually quite outdated when it comes to VWD diagnosis. And so we've had a number of meetings to make a proposal to them based on the strength of the guideline for what those diagnostic codes should be in the United States. And I think to pick up on Susie and Claudia's presentations, an idea for people coming out of the session would be to look at the guidelines when they're available, and then to think about your local regulators. And could you take those guidelines to local regulators and advocate for increased access to care, improved diagnosis, better treatment?
Okay, thank you. So there was another question for you, Paula, please, is it says, we are aware that some whole genome genetic testing is now including von Willebrand disease in the genetic disorders being tested. How can we best target education about how to follow up a positive result from VWD?
Yeah, that's a great question. So when I think about genetic testing for von Willebrand's disease, and we actually do in the diagnosis guideline have a couple of recommendations about genetic testing for 2B and 2N von Willebrand's disease. I don't actually consider whole genome sequencing clinically what we should be doing at this time. There's no doubt that genes outside of VWF are probably playing a role in VWF synthesis or clearance, but I don't think that our level of understanding has gotten to the stage where whole genome sequencing should be part of a clinical diagnostic strategy, and we certainly are not advocating for that within the diagnosis guideline. And so I see that as important for research, so that we can understand maybe how genetic testing could be improved in the future. If it's happening clinically right now, I think there need to be some questions about how people are interpreting the data they're getting and what that might mean for a patient, because I think there's still a big gap in our knowledge there.
Yeah, thank you very much. So there are several questions that I will group them into one question, and this will first, how do patients convey the message of the existence of the guidelines, and for especially the non-hematology healthcare professionals? How can the patients, liaise this or send this message? So this probably, maybe I ask Susie to answer this question.
So I think it could be something as simple as print it out and take it with you. If you go old school, sometimes a healthcare professional can't avoid it if you take the evidence to them, and then they've got something that they can research and look at. And at least that way you're not this person saying, oh, there's this thing I read online. They've got the evidence, they can follow it up, they know where it's come from, they understand, they should be understanding what blood advances is.
Yeah.
Print up your handouts and take them to your healthcare professionals. Leave them with your dentist, leave them with your physio, leave them with your primary healthcare professional as well. It's a really good basic thing to do.
Yeah, Thank you very much. The other part of this question is how to build the, the multidisciplinary team. How can we, from the hematologist's perspective, how can you build this multidisciplinary team? How can you split the knowledge among the different specialties or the different, and is there any role for the patient to interact with this? So Claudia, could you help us answer this group of questions?
When you have to build a multidisciplinary team, first you want to do it. I think the first barrier to do a multidisciplinary team is the physician himself. Then I think it depends where you are, how is the context of the country, you are in a center, it depends where you are. Certainly, the patient is really important. Again, it depends on your context. In our country, for example, our patients help us a lot because we don't have a center of care like everyone have. We have a center of care where people come, we have the registry, we can have some consultation, but usually our patients are seen in the region and they go to the doctors they want, they can afford to pay or whatever it is when it is a specialist. And usually we do the connection with them through the patient. So if you are in a standard hospital, I think it's easy. If people have the will to do it, it's easy to do it. The most important thing is the will, and you just have to sensitize the people around you that you think your patient can benefit from. And I think the majority of doctors in the same center will play the role if they want to do it. I don't know if I answer, but...
Yeah, I think so. Thank you, Claudia. So there is another question, maybe I will take the point of view of Paula on this, that in countries where they lack the resources for the sophisticated foam-relevant testing, like the ancient testing, the activity and the factor rate, would the bleeding tool assessment tools, in addition to the PT, APTT, would be enough to at least diagnose these patients? Because I don't think that this point has been thoroughly addressed in the guideline.
That's a great question and a great point. And no, it's not because of that high resource perspective, but it's absolutely something that will be explicitly considered with future activities. So I think the one thing that's great about bleeding assessment tools is that that it's the low-tech nature of it, the patient perspective on their bleeding, the patient history about their bleeding. And we certainly have started to look at trying to do culturally and socioeconomically and religiously appropriate translations of the self-BAT, which is a bleeding assessment tool that patients can administer themselves without the need for a healthcare provider. And so I think that tool very clearly shows who has abnormal bleeding and who doesn't. In terms of the lab testing, the bleeding time is not sensitive or specific. I acknowledge that I think in some settings it may pick up individuals who have defects of primary hemostasis, but the PT, the PTT, what you're going to pick up with the PTT, at least when it comes to VWD or hemophilia, are patients with more severe disorders. And so I think it's a reasonable place to start, but I think we do need to advocate for better ways of identifying individuals who might have milder forms of the disease, which doesn't mean they're not suffering from bleeding. It's just that maybe they don't have type 3 von Willebrand's disease with a factor 8 level that's 1%. So these things I think all need to be considered as things roll out. But thank you for the attention on the BAT, because I think that can be very helpful in many settings.
Yeah, thank you. I don't know, we are up to the time, so if we have like 1 minute, there are two related questions to Paula. So the first thing is, does the guidelines, has any ethnic specificities regarding dealing with the disease? And the second question, should we go away with the term of low von Willebrand factor, as might have implications for insurance coverage as compared to von Willebrand disease? So these two questions, if you can handle them quickly before we
Quickly, okay.
close. Yeah,
Yep.
please.
Yep. Okay, so the first question. We identified in the diagnosis guideline that more research on the diagnosis of von Willebrand's disease for different ethnicities is a major research priority going forward. We touch on it briefly when it comes to the ristocetin cofactor assay and the knowledge that we have around polymorphisms in the African American group and how that might influence ristocetin results. And so it's one of the reasons we actually recommend against using the ristocetin cofactor assay. And are advocating for the newer assays. So we touch on it. More research is absolutely necessary. The second question was
For
about
the term,
yeah. So yes, we absolutely considered this very carefully in that recommendation that I previewed in my presentation. And although the term low VWF, I think, has biologic meaning, it has unintentionally, I think, been a barrier to care for some people because insurance companies don't recognize it as a diagnosis. And so it is why we very clearly said, if you have abnormal bleeding and VWF levels that are below the bottom end of the normal range for your lab, you should be diagnosed with a disease, type 1 von Willebrand's disease. And our perspective there was to try to get over some of those insurance issues and make sure people had access to care.
Okay, thank you very much. So this brings us to the end of this session. I would like to thank all the presenters for their outstanding contribution to this very important session. And in the meantime, I would like us to thank the audience and ask them not to forget to handle the polling question in order to evaluate the session. And thank you very much. Bye-bye.
Hi, my name is Dawn Rodolini, and I'm with the National Hemophilia Foundation in the United States. We are a proud sponsor of the first annual World Federation for Hemophilia Global Summit for Women and Girls with Inherited Bleeding Disorders. A few initiatives that I wanted to share from NHF. We have a Better You Know website, reaching women and girls that have been underdiagnosed or not diagnosed at all. You can find that at betteryouknow.org. Also, we offer bilingual education materials in English and in Spanish. These include lab testing brochures, lab test logs for patients, healthcare diaries, undiagnosed for teens, girls brochures, and brochures for providers. And our Victory for Women website. Your stories and those like you share experiences on this site. You also can get expert answers to questions from women with inherited bleeding disorders. That's victoryforwomen.org. And finally, some publications to share with you. You can download these from our website. You can go to tinyurl.com, and it's Girls Puberty, BYK Girls, and Women Labs. This is where you can find brochures on Time to Talk Puberty, and that's for girls with bleeding disorders. It's Your Health, Own It, period. This is a brochure for girls to talk about their periods that have inherited bleeding disorders. And finally, what women and girls should know about getting tested for bleeding symptoms. We have a lot of opportunities and resources for providers as well. So please come by NHF's website, www.hemophilia.org, to check it out. Thank you so much, and we're super excited about this conference.
I thought I'd introduce you to a standing mindfulness exercise. We've been sitting a long time. So if you'd like, and if you are able, feel free to stand up. Perhaps standing behind the chair that you were sitting in, and feel free to rest your hands on the back of the chair in front of you. Stand in a simple, upright position with your feet hip-width apart. Your knees a little bent, your spine tall, the crown of your head lifted, and your shoulders relaxed. Feel every part of your feet in contact with the floor. Notice the connection of your 10 toes, the padded balls of your feet, the outside edges, the arches, the heels. Feel the weight of your body going down through your feet and into the earth. Try shifting your weight a little to the left and to the right, to the front and back. Then find a balanced place at the center. Feel the sense of stability, and perhaps notice that you are never completely still. You will likely sense little shifts and movements as you maintain your balance. Spend a few minutes tuning in to the sensations in your feet and the feeling of contact with the earth. And then whenever you're ready, whenever you decide, feel free to take in a deep breath. Open your eyes if they're not already open, and begin to move the various muscles in your body.